Welcome to the first of a three-part webinar series on the role of respiratory protection in response to coronavirus. This webinar is hosted by the International Society for Respiratory Protection, and this webinar will focus firstly on the public health emergency respirator demand and the response of new to respiratory manufacturers. The agenda for this webinar will be based on a 90-minute time window. We will have a brief introduction. I will present a little bit about ISRP, who we are, and what our mission is. We will give a brief overview of the public health emergency framework. Our panelists will share their stories on their response to this crisis. And we will have time for a brief question and answer session. I would remind everybody to please use the Zoom question and answer button to go ahead and type in your questions. They will be posted as they are answered, and we will handle them at the end of this webinar. So today's panel, it consists of myself, your moderator. I'm Michael Parham. I'm the past president of ISRP. We are joined by Brian Wolin. Brian, would you give a brief introduction?
Yes. Good morning. My name is Brian Wolin. I am the CEO of Protective Healthcare Incorporated. We are located in Paterson, New Jersey. And we are manufacturing filtering facepiece respirators that have been recently approved by NIOSH. Little background on myself. I was born in Brooklyn, New York. Went to college at Oneonta, upstate New York. I then became a chiropractor, which I became one in 1998. And then now I'm married with 2 children, one going off to college, and a 13-year-old as well, and very excited to be here today.
Thank you, Brian. We are also joined by Dan Cohen. Dan?
Thank you. So Dan Cohen, co-founder and CEO of 3D Bio, and now also American PAPR. I'll talk about the company in a bit, but we are a regenerative therapeutics company focused on growing living cartilage. And to meet the needs of the crisis, we developed and manufacture PAPRs. Got one daughter, 2 years old, who might be joining us any minute now. We'll see. But thank you. Happy to be speaking here today.
Good, thank you, Dan. We are also joined by Colleen Miller. Colleen.
Good morning, everyone. For those of you who don't know me, I'm Colleen Miller. I am the past chair of the Americas section of ISRP. My daily duties at work are the acting, or I am the Deputy Branch Chief for the Conformity Verification and Standards Development Branch in the National Personal Protective Technology Laboratory, the division of NIOSH that is responsible for administering the NIOSH Respirator Approval Program. I am in the office today. I have been working from home since the middle of March. For those of you that know my husband, he's off today and he's got a lot of plans for our kitchen, and we have workers coming in, so I decided the best approach was to be here in my very white and quiet office.
Great, thank you, Colleen. I'm really excited to have everybody's participation. We should hear some good stories. Brian and Daniel will be presenting for 20 minutes each with respect to their journeys. And Colleen will be joining us at the end for the question and answer panel session. So first, I do want to tell everybody in the audience about the International Society for Respiratory Protection, who is hosting this series. We were founded in 1983. We are a nonprofit organization, and our charter is to provide an educational and informational service to all individuals involved in respiratory protection. Our main purpose is to do things like today's webinar, bring together the professionals dealing with these challenges. Our members are people from relevant user groups, industrial hygienists, the manufacturers, the regulators, basically the international community behind respiratory protection research, use, standards, conformity, and helping society respond to crises like coronavirus with effective exposure controls. Our scope is international. We have equal membership across our 6 sections. We, of course, Colleen and myself come from the Americas section. We have a European section, and then in Asia, we have the Australasia section, Korea, Japan, and the Greater Chinese section. Our goal is to encourage health and safety of respirator users, help with best practices, promote and identify areas of research and evaluation that will aid the community. And we also encourage exchange of information, and through partnerships with organizations like Workplaces Without Borders, we also promote the effective use of respiratory protection devices in the developing world. I do encourage those who have not yet to visit our website at isrp.com to learn more, consider joining, and find out more about activities in your region. Now, I don't have to tell you what's going on. The coronavirus pandemic has put tremendous pressures on our society, and within the realm of respiratory protection, this has led to a significant, and some can easily say unprecedented, increase in demand on our healthcare professionals and also the manufacturers. So both established respirator manufacturers and those new to respiratory protection responded in kind. And this also required innovative approaches to support the approval of respiratory protective devices to meet the nation's needs. The reality was that existing supply chains were not able to produce sufficient RPD early on in the crisis. And so through the use of these innovative approval mechanisms, additional respirators were brought to the nation's healthcare workers. And this was done in 2 main steps. First, the FDA authorized a number of what are called emergency use authorizations. The first was to approve the use of air purifying respirators not normally FDA approved for use in healthcare settings for response to the COVID-19 public health emergency. This was dictated towards NIOSH approved devices only. The FDA also put through 2 emergency use authorizations that we will not be discussing in detail here for non-NIOSH approved disposable filtering facepiece respirators from China and other countries that would be imported. In parallel, NIOSH prioritized accepting and examining particulate filtering respirator approval applications. The types of respirators used for healthcare workers are but one type of a multitude of respiratory protective devices, and priority was given to those most relevant to the crisis. Furthermore, NIOSH created a limited and temporary public health emergency approval guidance that applied for particulate filtering facepiece respirators. We commonly also know those as N95s, and particulate filtering powered air purifying respirators. Now, this public health emergency approval is limited and temporary. It established a method for achieving an approval for these loose-fitting PAPRs and FFRs. It did increase the availability of respiratory protection to US healthcare workers when they needed it most during the initial phases of the crisis. These public health emergency approvals, however, are temporary. They remain active only for the duration of the public health declaration. These approvals are listed on the NIOSH certified equipment list and are authorized and used under the FDA emergency use authorization. The usage, these are meant to be used in a healthcare setting during a public health emergency under an FDA EUA only. So with that out of the way, I would like to hand things over to Brian Wolin.
Good morning. I'd like to thank everybody for joining today. I am very humbled and honored to be considered to speak to everyone here in this distinguished panel. And I would like to just go forward and discuss a little bit about protective health gear and what we've accomplished since the middle of March. Just to start off, why did I get involved in this particular industry? As I had stated for a moment before, I am a chiropractor licensed in the state of New York since 1998. I've been in private practice, examining and treating patients, again, for the past 22 years. And I really enjoy and appreciate taking care of people, and I'm always concerned about people's health and well-being. I also love to work a lot. And for the first time in 22 years, I stayed home from work, and I wrote the date down. It was March 17th of 2020. I had worked on Monday, March 16th, and the palpable fear that was in the workplace from my secretarial staff to other physicians in my group was at a level I've never experienced in my 49 years on this earth. And I remember coming home and listening to the president, the vice president, living over Cuomo, also listening to Governor Murphy. The coronavirus task force had just come about and started to speak every day. And I listened day in and day out for the next 2 weeks that I was home and not going out to work about the call to a plea to the citizens and people that were in manufacturing. We need personal protective equipment. We need it now. It's an emergency. Anybody that can do anything, please come about immediately. And I remember seeing people that were in sewing and seamstresses making cloth masks, watching television on the news, watching nurses wearing garbage bags over their clothing, over their regular clothing because they ran out of gowns, gloves being scarce, and of course, N95 respirators, watching nurses wearing masks with a very unknown and very deadly virus. And based on all that, I really felt this compelling need to want to help. And I have a very close family, and this is a very interesting story. My wife, whose name is Haley, has been very supportive throughout this whole process. Her brother is Evan Schulman, who is the COO of our company of Protective Health Gear. And Evan, we're a very close family, and we would discuss and talk about the situations and everything going on. And Evan, just as a background, Evan has a manufacturing facility in Paterson, New Jersey. He has an 80-some-odd-thousand square foot facility in which he manufactures and manufactured high-end displays and designs for the likes of Gucci and Chanel and many other high-end products. And after these products are made, Evan would put them into department stores and retail stores in which they would hold different products and devices. Well, needless to say, all of the department stores and all of the retail stores closed down. So Evan, like myself, was sitting at home with nothing to do. And so we discussed, and Evan, having such a big facility, said, Brian, I want to make PPE. And we went back and forth and said, what would be the one thing that we felt was the most important of any of the issues that we could possibly help with? And we picked one of the hardest ones, which was to make a NIOSH approved N95 respirator. So one day I decided to call the CDC, and I had gotten through to one of the branches, and I was lucky enough to get to speak to Colleen, and it was actually on a weekend, to Colleen Miller from the MPPTL, and she answered a lot of my questions, and we talked about the public health emergency and how there was such a need, and the process. So I remember making a joke with Evan. I had gotten off the phone. I said, wow, this sounds really difficult. And, you know, we kind of laughed, but we pressed forward, and we're here today on that. So the reasons I really got involved was to help the public, and seeing, you know, wanting to really cry out for these people, these heroes that risk their lives day in and day out, and that at the least we should be able to provide them with what they need, that they could go home, the first responders, and to their families safely, and not infect themselves and infect their family as well, for trying to save our lives. And that's why I got involved, and that's why Evan got involved as well. Some of the barriers that we faced, quite frankly, the CDC and NIOSH, it was a very complicated process. It's on a cursory level, it almost sounds that it would be an easy task to be able to do this, but sourcing materials, sourcing machinery, and going through the NIOSH approval process was very, very challenging. And so all of this work was done from a home setting. All of this was done with the fact that many and most places were closed in both Europe and overseas. Some of the machinery obviously does come from overseas. It's very hard to source here. And a lot of the ports had very limited shipping schedules, adding to increased times to be able to get the materials and machinery. It was also aviation being closed down from overseas. It was very hard to get things that way as well. Also hiring workforce, preparing a factory that was built for displays and designs, to be able to have a logistic flow, to be able to make these respirators now in a certain environment, and to be able to train people both remotely and on site. And there were many, many challenges to creating this type of device. But I have an utmost respect for the NIOSH approval, and I found that it was very informative. Sourcing the right materials, that, the melt blown, it's very, very hard to get a mask that leaks less than 5%, leaving a 95% left over, which makes it an N95. And sourcing the right materials and something we call leakage, to making sure it leaks less than 5%, is quite challenging. And we spent days upon days, hours upon hours, making this respirator, and making sure that, through testing remotely back and forth, to make sure that we can achieve what we need to pass the NIOSH approval process. It was really quite challenging, but something that we one of the best accomplishments of my professional career and of my life was to receive this. Another thing is, asking about what developers would need to respond to this, and in order to respond quickly to these public health emergencies. It's with regards to an N95, it is not easy to just say in one day, I want to make NIOSH approved N95 respirators, and then you're NIOSH approved. It took months and months of going back and forth. I started back at work in May, when things started to loosen up in the state of New York, as a chiropractor. And I wore various versions of our respirator during that time frame, trying to find not only one that's safe and effective, that filters out at least 95% of particulates at 0.3 microns. But after that, I started to focus on something that was comfortable. And the reason I did is, from wearing these 6, 7, 8 hours a day, I realized how cumbersome it is to wear these for that length of period. So we decided to try and get a material that was softer on your face, not something that would chafe your face. I found that from wearing some respirators that I felt that my skin would chafe around where the seal of the mask was. Also, the bridge of my nose I felt was getting cut or had abrasions on it. So we put a foam nose piece on there to make it comfortable. So we tried to make something that was comfortable, comfort, quality, and safe. So to protect and to make it a little bit more comfortable for people that have to wear these day in and day out. So that was something that was very important to us as well. But I think that anybody that would be interested in possibly creating these respirators, I think it's a wonderful thing. And clearly 7 months plus months into this pandemic, there still appears to be a need for these respirators, and they still appear to be in demand, and there still appears to be a shortage and a fear of a shortage coming this winter, especially with the numbers spiking now and the flu season that will be occurring in conjunction with the coronavirus as well. So that's my story from Protective Health Gear, and we're here for any questions that you may have.
Thank you, Brian. I really appreciate you taking the time to share your story. So now we will turn things over to Dan Cohen to share American PAPR Company's story.
All right, thank you. So I believe this presentation should be projecting. If not, someone let me know. So, thank you again. It really is, truly an honor to be presenting here, in particular because I'll tell you a little bit about the story, but I think much like you just heard, being able to respond to your community's needs, your state's needs, more broadly, the country's needs, it truly was, I believe, one of the most important things I've done in my life. And I'll take you through what 3D Bio is, how we got here. But it's a particular honor because this really it means a lot to us. So you're going to hear me talk about 3D Bio and also American PAPR. The relationship between those that we are 3D Bio, a regenerative therapeutics company that's been around for 6 years, and what we do is grow living cartilage body parts for therapeutic applications. So I started in bioprinting 18 years ago in 2002, undergrad through the PhD at Cornell, focused on developing what we now call bioprinting technology. Back then, there were, I think the best name we had was solid freeform fabrication of, living constructs. The term didn't exist. We were early, but, over the last 6 years in particular, we've been trying to translate that from an academic technology to a clinical grade technology. And, you'll see in a few minutes, that's why we had a lot of the infrastructure to move quickly and act. How we acted was creating American PAPR, which is a subsidiary that designed and manufactured, powered air-purifying respirators. So, our mission was creating living cartilage. That still is our mission, but we added a mission in March to provide protective gear. We are based in New York City. So unless you were in New York City or perhaps Seattle or one of the early hard-hit cities, it's kind of hard to describe what that really felt like. But as you just heard, there was a lot of fear. We work with a lot of surgeons as part of 3D Bio. We were hearing from them. They were afraid of dying, frankly. And what touched us even more is hearing that more than being afraid for themselves, they were afraid for their colleagues. They were afraid for their administrative staff. They were afraid for their nurses, their assistants. And, we had one call in particular with the surgeon that we work with on a different topic. And, our engineers happened to be on the line. We just stayed on the line afterwards, reconnected as an engineering team and said, this is really disturbing. We need to try to do something. Other little anecdotes, one of our vendors was retasking their manufacturing to provide components for refrigerated morgue trucks. Unfortunately, on our 30-person staff, 5 of our staff members, actually several of our staff members, lost up to 5 family members across our team, which, I don't know how else to describe it. It just frankly made us really upset to see healthcare workers risking their lives to help us. And, we felt that we need to do something to try to help protect them. So, when this hit, and I'll describe this on the next page in a minute, we felt that we had the infrastructure, we had a quality system, we had a manufacturing, infrastructure, we had clean rooms, we had design teams, regulatory teams, quality teams. We felt that we had enough electromechanical experience thanks to our bioprinting efforts that we could make these. And we went to our board, a couple of key board members in particular, Harlan Weissman, the former chief science officer of Johnson & Johnson Med Devices, also, Saul Barrer, the founder, former CEO of Celgene. And I said to them, look, I think we could do this. What do you think? And, beyond just being supportive, they said, if you can make these, you have a moral obligation to do so. So, that kicked it off. And obviously, we had experience in the medical space broadly, in design, in particular of electromechanical units, but no experience in PPE. And it's not trivial. As everyone, I think, on this webinar knows, there's nothing trivial about producing safe and effective respiratory protection. So, we kicked into gear. And ultimately, within 2 months of starting, we had received approval under the PHE for a PAPR 100N class. We use P100 filter media. We believe, we could have gone the HE classification for this first submission. We decided to go with the PAPR 100N pathway instead. But, none of this would have been possible without having some infrastructure in place already, but also in particular having, the partnership with NIOSH to figure out how to navigate this space. A little bit more about us, so we are vertically integrated, which in a pandemic is especially important because, as you also just heard, supply chains become elongated, they become uncertain, and the more interlinkages you have between various suppliers, the more risk there is. So the fact that we had everything from clean rooms on site, but also down to a machine shop, we were able to move quickly with, let's say, fewer disruptions than we otherwise would have had. So we manufacture our own collagen bioink, we manufacture our own 3D bioprinters, we do our own cell culture, but what that means is we have a very interdisciplinary team. So, the electromechanical engineers, really, mechanical engineers with a lot of electronics and electrical engineering experience, who made our FDA grade, clinical grade bioprinter, they took the lead. But, some of our chemical engineers, process engineers, they had great contacts with suppliers who could quickly step in and get us up to speed on appropriate selections of breathing tubes. And, it was really an all hands on deck interdisciplinary effort to try to get this done rapidly. As I mentioned, we had a quality system. Nonetheless, it took dozens, if not hundreds of additional documents being produced to upgrade our system to, really adapt it for PAPRs. And then, obviously we had no experience in the PPE space. We had no experience with NIOSH, but what we found is that it was a great experience working with NIOSH because it's the same governing principles as ultimately the FDA, which is to say, a number of people coming at it from a regulatory science perspective, show me the data, show me the evidence. How do you know this is safe and effective? And, ultimately it's the same governing principles. So, we felt it was a very reasonable process, and, we were ultimately able to, with NIOSH's help, get up to speed pretty quickly. And then digital manufacturing, we all know tooling could take 2 months. So we went with digital manufacturing processes such as CNC, which we had in-house, CNC milling, 3D printing, which we also had in-house, to try to obviate the need for some of this tooling to get to the unit quickly. And I show the clean room on the bottom right, because in many ways that was our benchmark. We realized we have a giant PAPR in our facility. It's called the clean room, P100 filter media. And we just said, hold on a second. Obviously we're not going to use those filters for a commercial unit, but we took apart filters that we already had to get to a prototype within 2 days. Initial prototype, we got to final design probably in about a week or two, or near final design. One of our chemical engineers, as I said, was all hands on deck. One of our chemical engineers brought in her sewing machine. We worked with a Broadway costume designer to try to find a hood design that was more ergonomic. We developed our own electronic control board. We did our own firmware programming. So again, we were very, very fortunate to have a lot of that interdisciplinary team in place with that vertical integration. But, ultimately it was sort of figuring out from first principles, how do you filter air efficiently? And, some of the bigger challenges were things like battery selection, interestingly enough, because, you have to also think of it from a supply chain disruption standpoint. What is the battery selection that is least prone to going out of stock? If you take something, some of these components in a normal world would have, let's say, 6 weeks lead time. We were anticipating 9 months lead time if some components went out of stock. So we had to, in many ways, design the unit, not for the traditional dimensions, such as cost of goods sold, but we had to design this ultimately to address supply chain disruptions, which means that, frankly, in some cases, there were divergence with what you might have thought would be the design requirements and what actually needed to be the design requirements. As I mentioned, collaboration with NIOSH was absolutely essential. And, Colleen was a big part of that. The entire team was a big part of that. But, we needed a lot of education very rapidly. One of the things that helped is that the PHE guidance came out very fast early on, which was an important tool. But for that, we were already preparing to go the full approval route, but obviously that, would have been a much longer process. It was also helpful that we did have the full application materials to reference, because if there were certain things we needed more clarity on, the first stop would be to look at the full application. And, that would sort of at least lay out the principles that are at play. But also the NIOSH team was always very willing to help educate us on interpretation of certain guidances or requirements. We found tough but fair, which is what you want in a regulatory body. Responsive, but most importantly, working what seemed to us to be 24/7. NIOSH would get on the phone on weekends, and that genuinely added that little bit of extra inspiration to us, because we're sitting there saying, okay, well, we're working 7 days a week. The regulators are working 7 days a week. We have absolutely no excuse. We have to just keep going as fast as humanly possible. And we kept telling ourselves every single day matters for very real reasons. Every day matters. So, ultimately, I think the PHE really helped. It helped get us to a reasonable spot quickly. Post-approval, we were able to help hundreds of people. That said, clearly there are some challenges when you're launching a new product during a pandemic. Supply chain disruptions, which influenced the design, persisted. So we had to constantly be planning for supplier shutdowns, long backlogs of input materials, and also even just figuring out how to keep our staff safe during, while operating as efficiently as possible. So distancing, testing, et cetera. One of the biggest challenges is balancing investment and inventory levels, because you have so many flavors of uncertainty. You have uncertainty as to how hospitals are going to react to a PHE. You have uncertainty as to how hospitals are going to react to a new entrant without an established brand in the PPE space. You have uncertainties in, well, normally I'd want to buy 6 weeks of components, but now for component X, I have to buy 9 months of components. These are really large risks for a company that's trying to ultimately enter the space to do good, but at the same time trying to assure that you don't blow up the parent company in attempting to do so. So balancing investment and in particular inventory levels, even post-approval, it is a challenge. And I'll speak a little bit more about some musings and ideas we have on that later. But high input costs, I'm not sure this is something to be proud of, but we likely have the highest COGS PAPR in the history of PAPRs, because we designed this for a pandemic. We designed this for supply chain. We milled the housing out of solid aluminum. We did that because we could avoid tooling time, the time it would take to come up with custom tooling. Again, a lot of the other selections were not really designed for cost at all. They were designed for speed. And as I said, unfortunately, hospitals have been inundated with a lot of, some very reputable companies coming to the scene to try to help. Also some who are, let's say less than reputable. And what that did, probably in the April, May timeframe, is make hospitals a little bit more wary of someone coming along with a product that isn't a well-known brand. And, whether that's further public education on the rigor of some of these things like PHE, or a little bit further clarity on PHE approval, these are the kinds of things that, can only help over time. But, ultimately, we found, if you find, you have to tell the story. You have to explain why you did it. You have to explain what standards you met. And, it certainly is an uphill battle when these hospitals, no fault of their own, have been unfortunately inundated with offers of equipment that really were not appropriate. Where we're going, so, we received the approval under PHE for the first generation. We've submitted for a full approval, second generation, and, we already are well into design on a third generation, which would address the cost of goods sold point that I mentioned. It would be lighter. It would have a lot of other improved features, especially on ergonomics. And, as thinking ahead, at a, let's say, broader level, it might very well be the case that we are not going to be able to avoid these sort of intermittent pandemics springing up. And, the kinds of things we could consider would be, first, how are we going to address stockpile? How are we going to address swapping out units within a stockpile and long-term testing? And again, going back to that point about really needing to tune investment levels, having clarity on that helps make investments. So that also leads to, just something we witnessed firsthand. Hospitals really were looking for some sort of guidance on, how that stockpile, once it's there, will be distributed. But the last two in particular, so as I said, hospitals got skittish. They didn't really know, and despite the fact that they had federal approvals to reference, they still didn't quite know how to deal with new companies coming to them. And, an idea that I'd always thought would actually help, they ultimately didn't want to go and take their precious resources and then realize that they wasted it on something that wasn't real. So to the extent that they're at a policy level in the future, one day could be some sort of a program to help mitigate that risk for hospitals, I think you'd find an increase in the efficiency of adoption of some of the new PPE that comes to the market that meets standards to try to help the problem. And lastly, at a policy level, there could be a consideration of sharing some risk, which is to say, if a company goes out and gets approval and meets the standards and makes a reasonable supply, just providing some level of visibility into what that demand signal really is going to be, so that you're not stuck with thousands and thousands of batteries or thousands of fans. And, again, none of these things are easy. But in the end of the day, we do see that hospitals don't quite know how to, respond and who to trust. And, there could be a role for policy to sort of mitigate some of those risks. So that is it. We started off the year making ears, living cartilage ears. We're still doing that. We're currently in discussions with the FDA to initiate clinical trials, hopefully in the near future. We've been fortunate to receive a couple designations from the FDA, so that program's moving along nicely. But, we're also very passionate about, if there's something we can make that helps people, that helps solve a need in the immediate sense, then, we're really passionate about that too. So, thank you.
Thank you so much, Dan, for sharing your story and providing some interesting context for our Q&A session, which is going to start next. I would invite our panel to start their video so we can all see each other. I am going to remind the audience to use the Q&A feature to raise questions. We definitely want to make sure that we're sharing information that's relevant to you. I will start off our Q&A session by first going to Colleen and asking you, since you were really at the center of all the activity from an informational standpoint, was there a common, I guess, set of information or knowledge that you feel developers needed and wasn't being served up by the community? What was kind of that most frequently asked question that you got?
Obviously, as Dan and Brian stated, I mean, there's always questions when you're coming new into a regulatory space. But I think particular to respiratory protection, some of the things that I really kind of rode people hard on, so to speak, when I first would speak to them, and Brian will attest to this, is understanding that the NIOSH approved respirators that are already in the market have an expected level of protection. So the users expect, you know, that when they put on an N95, it's going to fit them and it's going to protect them. When they put on a PAPR, it's going to protect them even more in some ways and do its job. And that the NIOSH approval is very much tied to OSHA. So in the pandemic, I think there was a very clear understanding of NIOSH and FDA and what the space is in terms of being, medical devices and used in healthcare. But I think that whole understanding about fit and the ability to clean and reuse and following the instructions that the manufacturer provides, understanding, the limitations of use. I think it was, we were constantly educating about that situation as well. In addition to the typical questions about, how do I even begin to apply for an NIOSH approval?
Okay, thank you, Colleen. Brian, I would like to ask you, you told a great story about your personal experience in your practice and how you were attempting to develop a product that could be used by healthcare workers. What aspect of respiratory protection most surprised you in trying to develop a product that could be effective?
Michael, first, the video I believe is off on your end. I tried to go back on, but I think you have to put me back on.
Okay. We will deal with that. We can hear you though. So
got it.
Oh, there
Thank
you
you.
are.
Okay, great. So could you repeat that question real quickly, please? Thank
Yes,
you.
yes. I was going to ask you, in your effort to develop a product for practitioners such as yourself, what surprised you most about the respiratory protection industry? What did you not expect to come across?
So I expected the process to be a little bit easier than it actually was. I found it very difficult. Again, just to go back, I found that Dan said many interesting things. The cost was very, very high. The investment involved in this was very large, but certainly well worth it. But I found that it was very hard to be able to create the blueprint, or I would like to, as we like to say, the recipe for this invention. I found that, taking multiple layers of different materials and putting them all together and then creating a device that fits your face properly, also welding, especially with head straps, how, ear loops are unacceptable. And after trying them on for so many times, rightfully so, you have to have a head harness to securely fit the mask or the respirator to your face. It's very, very, and you feel such a difference with having the head harness. You feel that the fit on your face is just so much more proper, and you feel that there's no air getting in, which is the key, is to prevent leakage. And using ear loops is something that, you could almost feel that leakage was occurring in that particular case, especially around the cheek area. So I found that finding the materials, being able to ultrasonically weld them together and to make sure that they leak less than 5%, and at the same time having a comfortable fit was some of the barriers to, or the difficulties that I didn't expect to be so difficult.
Okay. Well, thank you, Brian. So We do have a couple questions coming in. I do want to remind people that this isn't a normal Zoom meeting, so we can't throw a question directly to you. So please use that question and answer box to raise your questions. I did want to ask Dan, we did get a question. Can you inform about whether PAPRs are being used by hospitals? To what extent? And can you also talk about the adoption of respiratory protection programs by hospitals and to what extent?
So the short answer is yes, they are. I know of one hospital that has 3,000 of them, actually. I think, so this is to say, there is a wide spread in how hospitals approach this, both from the standpoint of how broadly they use them and how sophisticated they are. You know, just think of it, some of these hospitals are already set up to take Ebola patients. They have incredibly sophisticated procedures and systems, and some of them have thousands of PAPRs. Others, you know, other major, you know, institutions, some of the ones in New York, actually, some of the most famous hospitals in the world had five PAPRs in their entire hospital system. So, you know, that just illustrates the wide variation. So the answer is yes, hospitals use them pre-pandemic. Some use them a lot, some less. Now I'd say most do, but you know, it's also the private practice. You know, it's the five physician group. It's the individual dentist. It's the individual as well. And, you know, it's also what we found is that those in particular are the ones who are having the most trouble finding these things because they need them just as much. And in fact, in some ways, they're less tied to policies and some of the bureaucracy of larger institutions. So they can go ahead and get it. If they want it, they can go ahead and get it, but they can't find them because the larger institutions are being served first. So I think the answer is yes. There's a wide spread in how they're deployed. There's also a wide spread in how individual segments are served. So yeah, widespread.
Okay, thank you for that.
Yeah.
We do have a question that I believe Colleen could best answer, but I'm not sure also, Brian, if you have come across this. So we've had a question about informing this audience about activities to develop face coverings that have the same face fit and filtering properties as respirators for the general workforce who may not be used to wearing respirators and the general public.
Thanks, Michael. I did see that question, and I wanted to inform the group that ASTM F23 Subcommittee on Respiratory Protection is working on a barrier face covering standard. It's a work item 73471, and they have been discussing including an assessment of some assessment of fit and how that could work for a general use or an occasional occupational use type of face covering. So that's one of the most active approaches that I'm aware of. Michael, I don't know if you can speak to, I think ISEA might be working on something as well.
Yeah, I can't speak to that. I think the main thing is ICA is working in concert with ASTM to support the development of that standard. And of course, globally in Europe, a number of countries are individually working on standards for face coverings. And likewise, I do believe SEN is looking to raise that as a European standard, although I do not have that information readily available. I did want to follow on with that. So we are mentioning face coverings. We can't really speak to that in detail, and we will cover that to a certain extent in an upcoming webinar in November when we talk about the America's response. We will have a presenter who will talk about the use of respirators in non-traditional environments. So there may be some more detailed commentary there. I did want to offer up a general question to both Dan and Brian. And this came in, do any of these new companies intend to offer a product to meet the needs for the general public. We see a certain segment of the population wanting masks and respirators post-COVID-19, especially something that is reusable.
The short answer is yes. You know, PAPRs are reusable. You know, other kinds of devices are reusable as well. But you know, there is a need beyond even healthcare professionals. We've had inquiries from some high-risk school teachers, right, with pre-existing conditions. So, you know, we're here to help anyone. So it's not only healthcare professionals. You know, obviously, you have to sort of assess the risk profile. Some of that has to do with the individual. And then, you know, respiratory protection decisions are, you know, dependent on that. And, you know, as I said, if there's a high risk individual who's not even the healthcare profession, some of these things are appropriate for them. And yeah, we actually have been serving them.
Yes, for me also to speak on that as well. Certainly, I feel that it's very important for this to not only go to the first responders and healthcare workers on the front lines, but it's also so important for the general public to have access to this, just as Dan had mentioned, that there are many people that are immunocompromised, that have significant fears. I mean, there's a lot of psychological and emotional issues, and I think that having a face covering, having a filtering facepiece respirator for many people would help them get back to their normal lives. Colleagues and friends of mine are afraid to get on airplanes for, you know, even though they've done so much. I think having an N95 would possibly make people feel better. There are many teachers and healthcare professionals that won't go back to work. In fact, all over the news, they're talking about shortages of nursing staff because people are afraid to go back and risk themselves to COVID with this fall and winter season occurring. And clearly the fact that you cannot find these in stores anymore, in a Home Depot, in a Lowe's, in places that you would just see them lining the walls for the industrial industry, shows that there still is a shortage. And clearly the manufacturers are gearing towards the first responders, but certainly having more of these respirators to utilize would really, for the general public, I think would hopefully help also on keeping the transmission rates of these viruses down.
Okay, good to hear that need, and I think it's safe to say that organizations like ISRP, we are hopeful that we have effective standards to govern these face coverings so that we can ensure safe and effective products. I did want to raise that our European colleagues were kind enough to confirm that CEN is working on a face covering workshop agreement, looking at guide to minimum requirements, methods of testing, and use. So thank you to our colleagues from Europe for that. I did want to raise the question, and I say it goes to you. These are the tough questions, Dan and Brian. Being new to the community, these are issues, I'll preface it with stating that these are issues that have been and remain challenges for existing manufacturers. So it's not just you. But I did want to raise a comment with your product, Dan. What experience in terms of cleaning procedures have you had to deal with? Have you incorporated any aspects of your knowledge of needed cleaning procedures with your design? What type of feedback are you getting? What does the community need to do to help with cleaning?
It's a great question. I mean, so ultimately we rely upon, some of the, EH&S, environmental health and safety, experts at some of these really large hospital systems to advise us on how they typically think about these things. And obviously there are published standards out there as well. But I think what the question really reflects is that every institution addresses this same thing differently. You have, some, again, these are probably the larger hospital systems that gear themselves for very high cleaning throughput. So they're sort of running multiple lines of these units basically continuously, switching from one shift to another shift. And some of these hospitals that we've talked to have separate buildings where they have racks set up to just hot swap these things so they come off a line, they go into a separate, into one of these cleaning centers. Some of these hospitals are ultimately really relying upon vats of cleaning solutions so they could try to dip some of these things in a high throughput way. So you'll see that. You'll also see others who don't really have those kinds of infection control procedures in place as much. And a lot of that's the institution themselves and the way they've evaluated those risks. Some of it's also their need for throughput. So if you combine sort of their inherent approach to infection control with their need for throughput, you do see a wide spread there. For us, it's making sure we're looking at the guidances. It's making sure that we're consulting with people who run those really sophisticated programs so that we know what does best in class look like. And even though our first generation is not compatible with a vat cleaning, so sort of aerosol based approach where you put it into a chamber or you dip it in a vat, it's something we're obviously going to be designing in to a future generation, because we recognize that there is a need for that. Although, again, there are different segments. You have, private practice is not doing that. They don't need that. They don't need that kind of high throughput cleaning approach. They just need good infection control procedures and good cleaning procedures. So, for them, are you using appropriate materials? Are you providing appropriate guidance? Is your unit ergonomically designed to the point where you can access every part of it to clean it? All the basic kinds of things that you'd need to meet the requirement for cleanability. So in some ways, there are requirements for this. You have to meet requirements for cleanability. But you also have this cohort that's super sophisticated about infection control and high throughput. And they have their own needs, which impact design, in particular, sealing off all intakes so that you can actually do some sort of mass cleaning process.
Okay, thank you. Yeah, and cleaning remains a challenge for many end users for reusable devices. I was going to ask you, Brian, in terms of your product being an N95, and as we all know in this community, that the use of respirators is dependent upon an effective respiratory protection program. Can you speak about any challenges you've had, or just, I guess, stories or information relayed to you by your end users with respect to fit testing N95s in healthcare?
Certainly. So OSHA regulates fit testing, and so that would be fitting the product to the workplace. So many hospitals, before we're encountering when they receive our product, they say, please send us samples. We send them samples, and then they say, okay, we're giving it to our fit testing department. And then they go ahead and fit test us and get back to us several days later. We've had really great success. Some have said, that recently a hospital said we need 10 out of 12 people to pass, and we passed. And I think it all depends on the size and the face of the person that's wearing the mask. And that's why there are so many different styles of masks, shapes of masks, the sizes. I know that from hearing around, many people are complaining that they can't get small masks. That's a big issue that seems to be about going about the community. But fit testing seems to be an issue that needs to be addressed by each and every institution that's contemplating purchasing the respirators.
Okay, great, and it's good to have that reminder. Fit testing is one part, but also just in general, the need for a respiratory protection program to make sure that the respirators are applied appropriately for the hazards and that they are maintained and used correctly. So Colleen, you're very popular in our Q&A. I will try and prioritize the questions, but feel free to touch on any others that caught your interest. So the first thing, it would be useful for everybody here, can you give us a sense of how many new manufacturers came about during the COVID-19 response that NIOSH had to issue approvals for?
So there's several different boxes to that answer. Specific to the public health emergency approvals, we engaged with 12 companies for the filtering facepiece respirators and 5 companies, 6 actually, there's one in-house for PAPRs. those are the ones that actually came in and applied and either got gotten approval. We had others that did not achieve approval. So then we've been prioritizing our existing approval holders, and I don't know how to sum up that activity other than to tell you that as in early October, we had made over 600 approval decisions, and normally our target is 400 for the year. So we're well on our way to making twice as many approval program decisions this year as we normally would, if that gives you an idea of the scope of our work. In addition to that, we have been flooded with inquiries just to achieve the 3-digit manufacturer's code. Part of our process is when you come in to apply, we ask you to apply for a 3-digit manufacturer's code. It's simply a tool that we use to track your documentation and your hardware, your projects, your files. It's not meaningful. It's not meaningful like the FDA code. It's just a tool we use. But we were flooded with over 800, closer to 1,000 inquiries from around the world to achieve that 3-digit code and then ultimately apply for an approval. And so that is why we have been so consistent in posting our prioritization policy. I think the first one was our notice was number 24, then we went to number 27, and now we're up to number 31. I hope that answers the question to give a broad picture of what we've been doing.
Yeah, and I would say another comment that came in, we had somebody state, as an end user, we are grateful for tough standards. Thanks, NIOSH and NPPTL. So thank you for that.
I think the thing that we have noted that sets us apart is the quality assurance requirements. And the world is getting educated about that, and it makes us very happy because our traditional approval holders probably found, before this pandemic, probably thought that was the biggest pain in the neck that they had to deal with, but it's really showing itself to be very beneficial to all of us, ultimately, to have that ability to say, you've got to keep up your quality control.
Good. So I did want to take the opportunity, well, one, I was going to state, a lot of people in the chat are asking, how much does an American PAPR cost? How much does Brian's mask cost? This is not a commercial event, so sorry. We will share contact information for both companies. I did want to touch on a couple common, I guess, clarifications. So let's talk about a couple things. So first, and Colleen, you can speak to it. I can certainly just cover it briefly. Can you talk about the actions that NIOSH has taken with respect to ear loop style respirators, and why is that important?
So as we were at the beginning of this public health emergency and about to develop, first we developed the guidance for the PAPRs, and then as we were asked to develop the guidance for the filtering facepiece respirators, it became very clear that we needed to make a decision about ear loop suspensions. Our regulation does require that there be tension, that the respirator stay on your face. And then of course, OSHA requires the fit test on the individual user. So prior to the pandemic, if we had an application that came in with an ear loop suspension or an ear loop suspension that also had a clip, we would do what we called a novel head suspension evaluation, just to assure ourselves that this respirator, once approved, was going to stay on the person's face when they used it. And we decided early on that in order to address the needs of the nation, we needed to stick to what we knew worked, and that is the traditional 2-head strap suspension. And that is what we have been doing, and that's been noted in our prioritization policies.
Okay, good, thank you. And another common question, and I'll briefly touch on it and anybody can else jump in. Could somebody explain the difference between N95 and Can N95 respirators. I see more and more healthcare professionals using KN95s due to a shortage of N95s. What applications in particular to the COVID-19 pandemic response would you recommend the use of KN95s? I would first state ISRP cannot recommend or not recommend specific respirators in the context of this discussion, but I can state that the term or the type of respirator commonly called an N95 is specific to NIOSH approved particulate filtering face respirators. The KN95 designation comes from a Chinese standard on particulate filtering facepiece respirators. While this standard does have similar tests to the NIOSH requirements, it is not equivalent. There was an effort early on in the pandemic, which Colleen could speak to briefly, to evaluate KN95 respirators and issue some degree of guidance. However, I will note to those who may not have reviewed that literature, that information, that it was also found that not all KN95s met similar filtration requirements that N95s are required to meet. And then also Colleen did highlight that NIOSH approvals include a quality assurance process, and that also is different than the China standard. Anything to add, Colleen?
I would just say that I think that contributed to the number of inquiries that we were getting because of the confusion of Chinese manufacturers wanting to get coverage under the FDA's emergency use authorization versus achieving a full NIOSH approval. So we did offer a point of use assessment testing through our evaluation and testing branch, and that's all publicly available. We were trying to assist state, local governments, even the federal government, our partners, and hospitals, healthcare systems. You know, if in the crisis and contingency strategies that the CDC has posted, KN95s are going to be used, we offered, you know, to test them to a modified version of our standard procedure to at least evaluate the filtration efficiency. And all of that is posted on our NPPTL website.
Okay, thank you. We all know that respiratory protection is filled with terminology that may be confusing. So if anything, hopefully we can help address some of that confusion. I was going to note a member of our audience did note that in addition to Europe, the International Standards Organization, ISO, is also working on a new standard for respiratory protection for use during pandemic. This would be under ISO 16975-4. So this is a standard that is contributed to by global country members. It does not apply in the United States, but these are published international standards, which are typically referenced in the creation of local country standards. So thank you to Dan Warkander for bringing that up. I did want to switch briefly, and this is an issue that likely applies to both filtering facepiece respirators and powered air purifying respirators. We did have somebody raise the challenges of communication. There are some known issues with communication in a multitude of environments. Healthcare obviously will require a good degree of communication, both between practitioners and between practitioner and patient. Could anybody speak about their experiencing dealing with and addressing communication concerns? And then finally, I'll hand it off to you, Colleen, after either Dan or Brian answer it, to talk about what aspects of the new PAPR standard may apply to communication.
I mean, you know, first and foremost, a lot of our communication is nonverbal. And, you know, one of the benefits of a PAPR is that you can see the face. So we've heard from a number of healthcare providers that, you know, immediately upon trying PAPRs for the first time, they were actually really surprised how much it helped patients generally feel comfortable and also just practically communicate, especially patients who are harder of hearing, which a lot of folks are. So I think it's an inherent feature of a PAPR system in general. And obviously there are requirements around noise levels that also contribute to ensuring that a user of a PAPR is going to be able to communicate and also not damage their hearing. So I mean, when you combine the standards that are set for noise requirements with the inherent fact that you have a full shield effectively, as opposed to something that's obscuring the mouth, we've not heard any issues with communication. In fact, we've heard some people describe that it's really helpful.
Thank you, Dan.
Yeah.
Brian or Colleen?
So since we had so many inquiries come in for new approval holders, we did put together an innovation team so that if someone were to design something that is, unique or novel, and maybe they aren't sure in looking at our regulation how it fits in, we have a team that will address, and talk to them about their design. However, we are, of course, limited in what we can do based on, the existing regulation. And so we've really had to focus our efforts on, getting out what we know. First of all, the healthcare workers expect, and other workers expect and are used to using. I don't have a crystal ball to know what the future holds, but I think we all know, there will be change to come from this, and I'm curious to see what it is.
Thank you, Colleen. All right, I did want to address some of the questions that have come in. We've had a number of questions asking about N95 reuse. I would state we likely aren't prepared to talk about that in detail today. I do know for certain our last webinar in December will touch upon reuse, potentially our next one in November. Just some of the questions for the panel, if you did want to jump in, position on reuse, looking at the importance or highlighting the importance of a user seal check, especially after disinfection technologies have been used on an N95. And there are also questions around similar to reuse, but different issues, PAPRs and N95s and design aspects that may affect aerosol transmission. So when looking at those devices for infection control versus just respiratory protection of the wearer. So I don't know if anybody wanted to address that.
So I can address it from the approval program's perspective that,
Thank you.
Of course, anything that you do that, changes the respirator is different from what the manufacturer's user instructions and labeling indicate, is in conflict with the NIOSH approval, and you would, be using it outside of the context of that approval. However, because this is a crisis, a pandemic, CDC has offered guidance, and our researchers here at NPPTL have worked closely with manufacturers and others to do some research to validate some of these decontamination methods. And so the guidance that goes out is, we're hoping is it's the idea is to be robust and suitable to the situation. And I know that's confusing because NIOSH is housed in CDC. So it is confusing, but it's the reality that we are in.
Yeah, thank you. And I think that highlights the need that should be a future topic that ISRP brings to the forefront. It is a complex issue with a multitude of aspects that have to be considered and stakeholders that need to be involved in that discussion, along with the current science as applied to the questions around reuse. So we are going to be wrapping up soon, and I did want to let the panelists know that we will ask for some closing thoughts from you, but before I go through a couple more questions, and so probably one or two more questions here. I was going to ask Dan, there are a number of questions around PAPRs. As we see in the media, they are not the typical respirator. Most of the public sees the filtering facepiece respirator. So can you tell me about that process? Were you dealing with end users who were familiar with what a PAPR was, or were you also trying to educate them about the concept of powered air?
By and large, the people we were talking to knew what they were and understood the inherent benefits. The higher filtration efficiency. The fact that you don't need fit testing, right? So I think by and large people understood that, and even a good number of individual private practitioners not affiliated with large institutions, equally understood that. I think it really also depends on what field. Anesthesiologists know about PAPRs. A lot of different medical specialties know about PAPRs. Some don't, right? Some don't. And I think it's a little bit field specific. So sometimes, of course, there's some education around that. But I think we were surprised the extent to which, even though many institutions didn't really have many of them, they knew what they were. And they knew pretty quickly that they wanted them. They just, by and large couldn't find them, and many still cannot. Again, larger institutions are inherently going to be served a little bit more readily than smaller institutions or individuals. So, we're still seeing a need for that. But, if the question is, do people know about them? Broadly, yes, but not everyone.
Okay, thank you. So we had a couple different questions come in, and I will comment that in general, the standards arena is very busy these days. There are efforts to look at face coverings. There are efforts to look at looking at usage with respect to healthcare. There is a longer story we could have. We could have a whole day's worth of panels on the NIOSH FDA relationship in the category of surgical N95s, but that's not today. But thank you for those questions. We are continuing to see supply challenges in the United States, but also in places like Canada. For those who are listening from overseas and maybe want to replicate some of what went right here, I want to ask each of the panelists, and I'll start with Brian, what were the key success factors for you in responding to the need?
Thank you. The key success factors were certainly, I would like to, as Dan had stated, to really thank the NPPTL and NIOSH for their guidance in getting through this process. It didn't make it easier. It just helped to put us on the right path to be able to do what we needed to do to produce the quality of a product that was necessary in this particular case. And I'd really like to thank Colleen as part of that. Colleen Miller was very instrumental in that. Part of the successes, I think, was being able to get that supply chain, which is certainly very challenging. The main ingredient, as I had stated earlier, in N95, the magic ingredient is that melt blown, which filters out 95% of particulates at 0.3 microns. We've partnered up with some other people that are doing this and learning about the process of making melt blown. It is not an easy thing to do. It is very, very challenging, and there's a lot of failures before successes, and in many different ways. So getting quality melt blown is the number one part of success that we've had. And then learning to keep that melt blown on your face in the form of a mask, and to make the proper seal and to only leak less than 5% is another great success that we've had. And we are able to consistently get the supply that we need to be able to produce these. And we're looking forward to servicing healthcare and the public, and we're just so excited that we know that whatever number of masks that we can create in a year are that many more that wouldn't have existed if we didn't go through this process.
Good. Dan?
Key success factors, I think it was largely vertical integration, which meant that we could rapidly go through development, straight to manufacturing, right? So we had the production teams naturally in sync with the design teams, the idea that we could make prototypes instantaneously, the idea that we also, again, had, again, for what we do in cartilage, right? Just think of it this way. We have over 25 in-process and release test methods and assays, 15 of which are novel, right? So we had a fundamental capability to rapidly onboard new test methods. And I mean, the bottom line is there's nothing trivial about respiratory protection. There really is not. And certainly not if you're going to do it to a real standard. So, even something like developing, or rather just in-housing and qualifying an existing test method, completely non-trivial. We had to put 2 of our engineers on that, day and night until we got it right. And there were many test methods. So I think having that interdisciplinary team from design, manufacturing, just core capabilities around thinking about quality systems, thinking about regulatory requirements, thinking, all the way down to, as I said, incoming materials inspection, test methods, to be able to bring all of that together under one roof was essential. And I think beyond that, there were a couple test methods it wasn't practical for us to do in-house. We had to work with a test lab. Having their partnership, having them work through the weekends was absolutely essential. Having NIOSH work through the weekends was absolutely essential. So, I mean, it felt like a wartime effort because it actually was, and as I said, we take what we do at 3D Bio very seriously, but I think I speak for all of our engineers and our whole staff, and I say this truly was one of the most meaningful things we've ever done. So, I would just say thank you to everyone who made that possible, because us alone would not have gotten it done. It took us, and certainly plus the partnership with NIOSH in particular.
Thank you. Colleen?
Oh, thank you so much for this opportunity to be here with 2 of our newest stakeholders. And a shout out to New York, because all your panelists, I believe today, are native New Yorkers. So I think one of the things that was important was knowing that this was real. So from my perspective, having worked here at NIOSH and CDC for 12 years, and we were always trying to educate the healthcare community, trying to understand what needed to be done to prepare for the pandemic. And yet, here we are, we're learning every day. So just knowing that, respecting that, even though, like in my case, I was fortunate I didn't have a relative get sick until later on, and luckily didn't lose anyone, but what happened in New York was real, and not waiting till now to know that. I think another thing that really helped us was the multiple skill sets that we have on the team. I'm kind of the broader thinking person, so I was the one kind of tracking all of these people, and who was seriously going to be coming in and who, was just looking for information. And then I've got, my coworkers who've been doing this for 30 years that are so technically engaged in every detail. So when those PAPR questions came in, because they are complex systems, being able to answer those questions. I want to thank my team because we were able to work remotely. I mean, we took the whole approval program and said, you're going home. And, March 18th was supposed to be a trial, and we basically never came back. And so the initial reviewers, the quality assurance reviewers, the final reviewers, everyone was working from home. And because we believed in the mission and we believed we were making a difference, helped ever so much to keep going. And then I would say the ability to have the national lab and the lab to be able to stay open was hugely important. And we haven't even had a chance to talk about that, fully as a program. But clearly our the testing was still getting done that we needed to get done. And, so grateful to be able to do that. And then I would say that these ISRP relationships were sustaining. There were times when it was, very bleak feeling like no matter what we did, we weren't making enough impact. There's even today, we're all still concerned that there's not enough respiratory protection out there. And I think, you know, we're constantly talking to each other because it's such a, I told all these guys when they come in, welcome to this tremendously nerdy but committed group of professionals. And I think that's very true. And I thank you all for your friendship and for your support throughout this. And then lastly, I would say, I started my job at Corning Incorporated in my 20s doing fiber optic research. And, you know, I worked for the guy that helped make Gorilla Glass possible. So I think that just the technology that led to us being able to do all this, I'm so grateful for it. I don't know how we would have done it without that capability.
Great, thank you, Colleen. And on that note, we will wrap up this webinar. I will say, I hope this provides a positive note in these challenging times, how we can all make an impact when we pull together, and what can be done when we leverage our communities of sharing and focusing on science and using science to guide the best response we can do given limited and challenged resources. I did want to go ahead and let the audience know that this was number 1 of 3. We will have a webinar on November 18th highlighting the Americas response to COVID-19. And I will note that Americas comprises not only the United States. I know some of our international colleagues probably felt this was a US focused session, and it was, but we will give Canada and members of the National Research Council a chance to talk about their response. We also will have a presentation from Margaret Sietsema of University of Illinois and in her work with CIDREP to look at considerations for non-healthcare workplaces and how they're dealing with the provision of respiratory protection. In December, we will focus on the European response, and this will be in a master class format that will comprehensively go from the nature of the biological hazard, the procedures around it, have those involved in certification, but also have a member of the Italian Healthcare Service speak about the early days of the crisis and how respiratory protection played a role in that response. And lastly, I do want to thank the individual and organizational members of ISRP. I do know that not only are they part of this community responding to this crisis, and for that we thank them, but also their contributions over the years as members to ISRP enables us to host events like this based on the questions. We need to do better at getting out the information, and we are working to do that. And this webinar and the questions we received has certainly given us the focus that we need to go ahead and make sure that we're providing the relevant information to this audience. So I want to thank all of our panelists again. And for that, we will now end the webinar. Thank you, everyone.
Thank you, Michael.
Thank you.
Thank you, Dan. Thank you, Brian.
Thank you, everyone. Thank you so much.
Thank you. Bye-bye.
Bye now.
Bye.